Hello guys, welcome all of you to today's Pharmcast. I'm Dr. Ranchan, your pharmacology faculty at Meru. So before I move ahead guys, I would like to wish all of you a very happy new year. And I could not post this podcast earlier because I was out of India. So I've just arrived and I'm recording this podcast. So anyways, I hope you guys must have celebrated your new year with all pomp and show. And now coming back to the podcast, guys, our aim today is to cover autonomic nervous system, and I hope you guys are covering based on our schedule. And again, I'll be discussing some important points and PYQs according to our book, that is One Touch Pharmacology, which many of you are using for revisions, right? So see, autonomic nervous system in the One Touch Pharmacology book, it comes on page number 11. And page number 11, guys, is where there is introduction to ANS. There are few MCQs, only few MCQs in introduction. And it is mostly related to the neurotransmitter of parasympathetic nervous system, that is acetylcholine, right? So first of all, what has been asked in the last 5 years? Number one is, an MCQ is asked, how can I decrease release of acetylcholine, right? By blocking which ion channels in the presynaptic membrane? Is it sodium, potassium, calcium, chloride, etc.? And you know the answer, that aminoglycosides, right? They block presynaptic calcium channels and block release of acetylcholine. So your answer is calcium channels. And even they have asked you earlier, which class of antibiotics can block release of acetylcholine or can cause neuromuscular toxicity? And that is acetylcholine, right? Second, the most recent MCQ that asked you is which toxin, yes, which toxin can block release of acetylcholine? And the second MCQ was how botulinum toxin acts. It's the same MCQ, guys. Botulinum toxin, it directly blocks release of acetylcholine. So both MCQs can be solved from these. Now, one more thing I'd like to tell you here is that what they can ask more than this is, if aminoglycosides, they cause neuromuscular toxicity, that what could I possibly use for treatment of the toxicity, guys? I can use calcium. Calcium is the drug of choice for aminoglycoside induced neuromuscular toxicity. So this is what they ask you mostly in neurotransmitters. Now coming to receptors. Now try to understand this. Receptors in autonomic nervous system, you must go through receptors to understand the drugs, their mechanism, their uses, their side effects. But per se, MCQs directly from receptors are not asked. Except one receptor which they commonly ask is about the beta 3 receptors. Where are they located? They're located in the adipocytes. And what do they cause? Lipolysis. So lipolysis is caused by which receptor? Beta 3. Where are they located? Adipocytes. Other than that, in ANS, receptors are not that commonly asked. But you need to know receptors to understand the drugs, right? Now, in the introduction page, in this page, what else they ask you is about poisoning, right? Poisoning, cholinergic poisoning, anticholinergic poisoning is a very commonly asked MCQ. In the last 5 years, in different exams, you can see there are at least 5 to 6 questions on this. So whenever we are dealing with cholinergic poisoning, right? Cholinergic poisoning will increase everything in our body. It would increase everything in our body. And in cholinergic poisoning, there would be, increase in everything in the body except in the heart. Heart, everything will decrease. So all secretions will increase. There is salivation, lacrimation, right? And there is contraction of bladder. And because of that, there can be involuntary urination can be seen. Similarly, involuntary defecation can be seen. Pupil will contract, small size, right? But heart will decrease. So heart rate goes down, there is bradycardia. So these are the symptoms of cholinergic poisoning. And the drug of choice for cholinergic poisoning is atropine. Now coming to one PYQ, a previous question which was asked is, which of the following is a feature of muscarinic poisoning, right? One option was bradycardia. Another option was diuresis, right? Now students were confused in between these two options. Now, obviously, we know that there would be bradycardia. And I also said in cholinergic poisoning, there would be, involuntary urination. But is involuntary urination is equal to diuresis? No guys, diuresis is urine production, filtration of plasma by the kidney, and that formation of urine is called as diuresis. So remember, diuresis is not affected by your parasympathetic nervous system, right? Diuresis can be affected by a drug like dopamine, which can dilate the renal blood vessels, right? So here your answer was bradycardia because diuresis is not affected in cholinergic poisoning. There can be involuntary urination. Similarly, now coming to anticholinergic poisoning, guys, everything is going to decrease in anticholinergic poisoning. So, oral secretions will decrease. There is dry mouth, urine retention, constipation, mydriasis. There can be hyperthermia, right? Tachycardia from the side of the heart. So once you diagnose anticholinergic poisoning, what is the drug of choice? Physostigmine. So usually see the MCQs on cholinergic poisoning or anticholinergic poisoning is based upon diagnosis. Either you have to diagnose the poisoning or they will ask you about the treatment of poisoning, right? How are you going to treat it? So cholinergic poisoning, atropine is the drug of choice. Anticholinergic, physostigmine, right? So that's all in this first page. Now moving on to the second page where we are going to discuss parasympathomimetics. So page number 12 in One Touch Pharmacology. Parasympathomimetics, see broadly you can classify them into direct and indirect, right? Direct are the drugs which stimulate muscarinic or nicotinic receptors. Indirect are those drugs which block ACHE, enzyme acetylcholine esterase. Now the direct one, nicotinic agonists, where you have drugs like nicotine, varenicline, and here there is only one point, nicotinic poisoning. Antidote for nicotinic poisoning. See, whenever there is nicotinic poisoning, there are different symptoms. And for that, we have to give symptomatic treatment, right? But in nicotinic poisoning, there is cholinergic excess because of stimulation of nicotinic receptors in the ganglions, right, of the parasympathetic nervous system. And that is why atropine is an antidote that can be used in nicotinic poisoning. So this is a paradoxical thing. It seems paradoxical, but it is not. So it has been asked. Now coming to muscarinic agonist. See, muscarinic agonists can be classified into amides and cholinesters. In amides, we have drugs like pilocarpine. So pilocarpine, the MCQ which mostly they ask you is based upon its use in glaucoma. That is closed angle glaucoma. And it acts by increasing trabecular outflow, right? And pilocarpine side effects, you can remember as BAR, B-A-R. Pilo, in Hindi it's like pilo. And to drink, pilo is drink. To drink, you have to go to the bar, right? So brow ache, accommodation spasm, retinal detachment. These are three side effects which can be seen. Whereas in cholinesters, we have a drug called as acetylcholine. What is the only MCQ they ask in acetylcholine is why can I not use acetylcholine by systemic route? See, I cannot use acetylcholine by systemic route. The very reason is it is very short acting. Why is it very short acting? The reason is because it is metabolized by plasma cholinesterase. So any drug that is metabolized in plasma is very short acting, right? Other drugs here in cholinesters, they are derivatives of acetylcholine like betanicol, carbachol, methacholine. Among these, mostly the drug that is asked is betanicol. So at least you should know betanicol, which is more preferred for clinical use, right? Carbachol, methacholine are less preferred. So betanicol is mostly used in bladder. In bladder, betanicol will contract the bladder. So it is used in bladder atony or for post-operative urine retention. So that is the most important part. Now coming to the indirect ACHE blockers, indirect cholinergics or ACHE blockers. Here the most important drugs are, organophosphates. By far, this is the most commonly asked class of drug, organophosphates. And the most commonly asked MCQ is what kind of block do they produce to the enzyme ACHE, right? So they are competitive blockers. Number one, they are competitive and they are irreversible. Two words you need to know. Organophosphates are competitive, irreversible blockers of ACHE. It has been asked so many times in the last 5 years, right? Now, organophosphates, obviously, they are used as insecticides and pesticides, and that is the reason why they are associated with cholinergic poisoning. And if there is cholinergic poisoning in organophosphate poisoning, drug of choice is atropine. But the most specific drugs are oximes like pralidoxin. Now, another question arises here is, if I'm going to use atropine, is again asked, that what is the indicator of adequate atropinization, right? Now remember, the most specific indicator or the best indicator is normalization of respiratory secretions. It's more specific, it is the best one. But it is how difficult to measure respiratory secretions. And that is the reason why the most commonly used is which one, guys? Which one? Normalization of the pupil size. Whereas coming to the second one, carbamates and non-carbamates. See, in carbamates and non-carbamates, there can be poisoning because carbamates are also used as insecticides, pesticides. But if there is a carbamate poisoning, I can use atropine as an antidote, but I cannot use pralidoxime. That is first thing. Second, in this carbamates, there are two types, tertiary amines, quaternary amines. And tertiary amines, the most important drug is physostigmine. And physostigmine, see, the use of physostigmine is drug of choice in case of anticholinergic poisoning. Yes, is drug of choice in anticholinergic poisoning and like datura poisoning or atropine poisoning, right? So, if it is cholinergic poisoning, I use atropine. If it is anticholinergic poisoning, I use physostigmine, right? The other drugs which are used here, like donepezil, rivastigmine, galantamine, tacrine, guys, these are drugs which are used in Alzheimer's. Quaternary amines, edrophonium, is very frequently asked because it is related to a disease in medicine, that is myasthenia gravis. And edrophonium, it is a drug of choice for diagnosis of myasthenia gravis. It is also drug of choice for differential diagnosis of myasthenia gravis from cholinergic crisis, right? And neostigmine is most commonly asked about its use in NDMR reversal. Plus, it is also used in cobra bite, bladder atony, post-op urine retention. So this is where the MCQs are asked. Whereas pyridostigmine, it is a drug of choice for treatment of myasthenia gravis. So here the clinical uses are more important, which they ask here. Now moving on to page number 13. See, in page number 13, guys, as you can see, is parasympatholytics, muscarinic antagonist, nicotinic antagonist. Muscarinic antagonist, here the MCQs mostly they are asked upon the pupil. And in pupil, they ask you about what is the effect, mydriasis and cycloplegia. And these drugs which produce mydriasis, cycloplegia, this is a drug like tropicamide, atropine, homatropine, cyclopentolate, right? So they ask you how they are different from sympathomimetics like ephedrine or phenylephrine, right? Ephedrine or phenylephrine like drugs are only mydriatic but not cycloplegic. But parasympatholytics are both mydriatics and cycloplegics. So they have asked PYQs, they've asked you how the PYQs are asked is which of the following drug is a mydriatic but not a cycloplegic, right? Then your answer would be a sympathomimetic. But if they've also asked which of the following is a mydriatic and cycloplegic, then your answer is a drug like atropine or tropicamide, right? Second one is they do ask you about parasympatholytics, which are muscarinic antagonists like glycopyrrolate. See, glycopyrrolate, it is preferred as a pre-anesthetic medication to decrease respiratory secretions, right? Second MCQ they ask you, PYQs, is which of the following anticholinergic is a quaternary amine or does not cross blood-brain barrier? Your answer is glycopyrrolate because it's a quaternary amine, it does not cross the blood-brain barrier. In the lungs, muscarinic antagonists which produce bronchodilation, they are used for COPD. And for COPD, I prefer LAMA, long-acting muscarinic antagonist. So you should remember at least one drug, that is tiotropium. What is the drug of choice for COPD? Tiotropium. And once a day dosing, what is the most common side effect of inhalational tiotropium? Yes, guys, come on. What do you think? It is dry mouth, isn't it? In the heart, see, in the heart, if I use anticholinergics, they will increase heart rate. That is why atropine is the drug of choice for treatment of bradycardia. That is one PYQ that has been commonly asked. Second is, what should be the dosing? The dose should be more than 0.5 milligrams because if I keep the dose below 0.5, then there is a risk of paradoxical bradycardia, right? In GIT, not much MCQs are asked, guys. The most commonly asked MCQ in GIT is about motion sickness. Anticholinergic preferred in motion sickness is scopolamine. They ask you also about the route of administration. It is transdermal. They also ask when the patch has to be applied. Your answer is 4 to 5 hours before the travel. So these are the MCQs which have been asked in your exams, right? Bladder is commonly asked. In bladder, see, anticholinergics, they are used for treatment of, because see, anticholinergics will relax the bladder. So they are used in overactive bladder, or which is also called as urge incontinence. So we have some drugs here, non-selective and selective. And just remember the selective ones: darifenacin, solifenacin, tolterodine. These are selective ones. So if you don't remember non-selective, then also it is fine. Now coming to PYQ. They had asked you a few years back that tolterodine is a drug that is used in overactive bladder because it blocks which receptor? M1, M2, M3, M4. And your answer is M3 receptor, right? So some MCQs, they are asked here. Now coming to, let's move on to the page number 14 in the book One Touch Pharmacology. Now page number 14, it is mostly about sympathomimetics, right? And sympathomimetics, as you know guys, we can broadly subclassify them into 3 types: direct acting, indirect acting, mixed acting. Now the indirect acting, mixed acting, these are smaller classes. First of all, let us talk about the direct acting ones. The direct acting, they are either catecholamines or non-catecholamines. And catecholamines can be endogenous and exogenous. Now endogenous catecholamines, there are 3, and I'll tell you only the most important, the most frequently asked, 90% of MCQs which are asked on those points. Epinephrine, the most frequently, single most important point is, where is the drug of choice? And all of you know the answer. It is anaphylactic shock. Route is also asked, intramuscular. Dilution is also asked, 1:1000. Dose is also asked, 0.3 to 0.5 milligram. Norepinephrine is not used by intramuscular route. Its route is only IV, and it is a very, 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 very potent vasoconstrictor. That is the reason why it is drug of choice for vasodilatory shock, like in sepsis. It is drug of choice in neurogenic shock. It is drug of choice in cardiogenic shock. These are the uses of norepinephrine. Now, dopamine is a drug that is somewhat similar to norepinephrine. Uses are similar to norepinephrine, but it is not preferred more than norepinephrine because the outcomes are better with norepinephrine. So what is it that they ask here, and what is it that I need to remember with dopamine is only their dosing, right? At doses more than 0 to 2, they stimulate D1. More than 2 to 10, they stimulate beta 1. More than 10, they stimulate alpha 1. And the effect is obvious. More than 0 to 2, D1 means diuresis. More than 2 to 10, beta 1 means cardiac contraction. More than 10, alpha 1 means vasoconstriction. That's all guys, that's all they ask in dopamine, right? Whereas exogenous, there are 2 drugs they only ask, dobutamine and isoprenaline. Dobutamine is a stimulator of beta 1 receptor in the myocardium, and it increases contraction, but it is not a stimulator of beta 1 receptor in SA node, so it maintains a normal heart rate. So yeah, is there one MCQ, that is, which catecholamine increases contraction of heart but maintains a normal heart rate? Your answer is dobutamine. And second MCQ is EUs, which is the preferred catecholamine in acute CHF, dobutamine. Isoprenaline is rarely asked, guys, rarely asked. If it is asked, it is mostly about its receptor, selectivity. Is selective for beta 1 and beta 2 receptor. Now coming to non-catecholamines. See, non-catecholamines, you have drugs like alpha 1 agonist and alpha 2 agonist. See, and obviously you have beta agonist. Now alpha 1 agonists like phenylephrine is most commonly asked. They ask the drug of choice. Is drug of choice in spinal anesthesia induced hypotension without bradycardia. Now remember, phenylephrine itself can cause bradycardia. That is the reason why you have to see if it is a case of spinal anesthesia induced hypotension with or without bradycardia. If it is without bradycardia, I'll go for phenylephrine. If it is with bradycardia, then I'll go for ephedrine. Second drug here, they ask about midodrine. Midodrine is the drug of choice for postural hypotension. Now coming to alpha 2 agonist, clonidine, it is obviously used as a second line drug in hypertension. But mostly clonidine, they ask you about the side effect, that is withdrawal hypertension. And in withdrawal hypertension, they have asked you what is the cause. Your answer is alpha 2 receptor downregulation is the cause of withdrawal hypertension. The other drugs which are less commonly asked, one of them is alpha methyl dopa, is frequently asked what is its use. It's used in PIH, pregnancy induced hypertension. The other drugs, apraclonidine and brimonidine, these are drugs from ophthalmology, and they do ask you about side effects. Like apraclonidine, side effect is lid retraction and mydriasis, whereas brimonidine can cause drowsiness and apnea in neonates. Now, beta agonist. See guys, beta 3 agonists like mirabegron and vibegron. Up until now, the only MCQ that has been asked is in the last 2 to 3 years is which of the following is a beta 3 agonist, and an answer was mirabegron, right? So just names are important. They're used in urge incontinence. Beta 2 agonist, you know the drugs SABA, LABA, VLABA. The names of the drugs are not asked nowadays, but still, what is that is commonly asked? We need to discuss here, and you can see in the One Touch book, I have only colored the side effects in red color, right? Side effects: palpitation, tremor, hyperglycemia, hypokalemia. And invariably, most frequently, the only thing they ask is which of the following is not a side effect of salbutamol? And your answer is hypoglycemia, because it does not cause hypoglycemia, it causes hyperglycemia. So guys, in the book you can see I've covered everything I've colored in red color, which are the MCQ points. Now coming to the last page in autonomic nervous system, sympatholytics. See guys, sympatholytics, alright, before I go into sympatholytics, I forgot to tell you about the other two parts: indirect acting sympathomimetics and mixed acting. See, this is smaller classes. Indirect acting, we have drugs like methylphenidate, amphetamine, both have same uses. Both can be used in ADHD, right? And both can be used in narcolepsy. But the drug of choice in ADHD is methylphenidate. Narcolepsy though, these are not the drug of choice. The drug of choice for narcolepsy is modafinil. So sometimes they ask you. But the problem with methylphenidate or amphetamine-like drug is they can worsen tics, and they have, the chances of addiction. So what if there is a kid of ADHD with Tourette syndrome or family history of drug abuse? In that case, I don't go for methylphenidate or amphetamine. I rather go for atomoxetine, which is a selective norepinephrine reuptake inhibitor. Mixed acting drug, there is only one drug which is important here, ephedrine. Ephedrine is exactly similar to phenylephrine in its uses. The only difference is ephedrine is preferred for spinal anesthesia induced hypotension if there is bradycardia, right? In the baby, if there is bradycardia. Sorry, in the mother. Now sympatholytics, direct acting, indirect acting. See, direct acting these are blockers, alpha blockers, beta blockers, right? Alpha blockers, the reversible ones, non-selective reversible one like phentolamine. There are 3 MCQs with phentolamine which are asked. It is drug of choice for clonidine withdrawal hypertension, cheese reaction, and intraoperative hypertension in pheochromocytoma. Right, so remember phentolamine, just remember phentolamine in 3 conditions. Phenoxybenzamine, it is drug of choice for pre-operative hypertension in pheochromocytoma. But remember, if there is a case of pre-operative hypertension in pheochromocytoma, then I cannot use only alpha blocker. I also have to use a beta blocker, and the sequence has to be alpha block followed by beta block. It's frequently asked. Whereas selective alpha blockers are like prazosin, terazosin, doxazosin. They're preferred or drug of choice for hypertension with BPH. And prazosin is also drug of choice in scorpion bite. It's frequently asked, guys, frequently. In the last 5 years, 3 to 4 times it has been asked. What is the drug of choice for scorpion bite? It's prazosin. Whereas tamsulosin, silodosin, these are more selective for alpha 1A, and they are preferred if it is a case of isolated BPH. Now this is what they ask you here mostly. And beta blockers, see, mostly the uses are important. Where are the drug of choice? The drug of choice for hypertension if it is associated with migraine, anxiety disorder, essential tremor, hyperthyroidism. The drug of choice in migraine prophylaxis. Drug of choice in HOCM, I prefer metoprolol. The drug of choice in aortic dissection, I prefer esmolol. Right, so these are commonly asked in beta blockers. Now see, as far as the name of the beta blockers are there, if it is too much of a trouble to remember the names of classes of beta blockers, you can forego. Just forget about the drugs which belong to a particular class. Just remember one class, cardioselective. The mnemonic that I've given to you in One Touch Pharmacology is cardiologist Mr. Bean, celiprolol, metoprolol, betaxolol, bisoprolol, esmolol, atenolol, acebutolol, nebivolol. Now all of these are second generation cardioselective. Only three are third generation. These are celiprolol, betaxolol, and nebivolol. So there is one mistake in the book, that is I have colored bisoprolol in green color. which I should have colored betaxolol in green color, right? So it's betaxolol, not bisoprolol. Change this in the book, right? Second MCQ, which is clinically, they ask you about contraindication. See, beta blockers should not be used in bronchial asthma and COPD. The reason being they will, produce bronchospasm. In diabetes, what could be the problem with beta blockers? They can block symptoms of hypoglycemia, except one, that is sweating, right? Other beta blockers, if you are not able to remember, then it's okay, guys. Then it's okay. I mean, nobody's going to kill you for that. MCQs are not that commonly asked. The indirect acting drugs, the commonly asked are VMAT2 inhibitors like tetrabenazine. See, tetrabenazine, it is drug of choice for tics associated with Tourette syndrome and Huntington's chorea. These are two commonly asked MCQs. Deutetrabenazine, valbenazine, these are longer acting than tetrabenazine. These are drug of choice for tardive dyskinesia. So these are, two drugs which can be commonly asked in your exams. So guys, this is what they ask in autonomic nervous system, and if you're not able to remember everything in ANS, it is fine. It's okay. There's no big deal. Just at least remember whatever I have marked in red color in this One Touch Pharmacology book. So many of you guys keep on asking me, sir, how to buy One Touch? See, One Touch Pharmacology is available on Amazon, Flipkart, you take any online platform. And I would like to thank all of you guys again for making One Touch Pharmacology the best-selling pharmacology book in India. Yeah, it's still holding right strong the ground, and for the huge demand that you guys have produced for this book. And I'm really happy that my hard work on this book, it was worthwhile, right? Because I brought out this book keeping something in mind that you guys have constantly been bugging me with is, we're not able to retain. I'm not able to make the 20th notebook. I don't know how to make it. So if you cannot make it, so I made it for you guys. It was based upon the demand that you guys had created. And the follow-up is this podcast. So what is the use of this podcast? Please don't use your active time listening to this podcast. I don't want you guys to waste your time on this podcast on active time. Please use your passive time. Passive time, like as such, suppose you're going for an evening walk, or suppose you're having a cup of coffee and you're relaxing, right? Or you're in the gym, or suppose you're driving to somewhere. So just use any kind of passive time, just plug in. Or suppose, I give a sweet music to this podcast so that some of you guys can use it just before going to sleep, and it will put you to sleep, because the music is like that. And it's not about my voice, but the music, right? So guys, as in every Pharmcast, I discuss one of your doubts, one of your problems that you ask me is, so one of the students, he had asked me is about, sir, now as the days are approaching, my anxiety is hitting through the roof, and because of that anxiety, I'm not able to study. My 3 to 4 days, the last 3 to 4 days, they have been wasted just like anything. And now that is again building up to the anxiety. Now guys, try to understand. You guys are humans. We are all humans. We are not programmed. We don't run on artificial intelligence. We run on hormones, right? And on neurotransmitters. And these hormones and neurotransmitters, they are cyclical. They go up and down depending upon the exogenous stress that we have. So you know that there are a lot of expectations. You have an expectation from you yourself that you want to see yourself somewhere down the line after 3 years or 6 years doing something, and that is what you are working towards. Your girlfriend or boyfriend has an expectation from you that you are right, you'll settle down, then you'll have a life afterwards. The most important people in our lives, they are parents, right? And they have expectation from us that they want to see us. And secondly, like most of us where we belong to lower middle class, we have a kind of expectation from ourselves, so that whatever our parent could not enjoy in their lifetime supporting us while we were cruising through our career, we want to give it back to them. It may be in any form, a house, a car, anything. So these are the dreams that we have as lower middle class people. I had these dreams that I could do something for my parents, and believe me, these dreams, these hopes, they create a pressure on us for performance. And these dreams, they are like fire, and we are like raw iron. And as raw iron, from raw iron to get converted into the steel, we need this fire. We need this fire. This fire is what makes us best, makes us unstoppable, makes us sturdy, right? So whenever you are down, whenever you are anxious, just remember, why are you doing this? Just ask yourself, for whom are you doing this? And let that fire burning, and let that fire keep you moving ahead. Think about your parents, think about your whom you love and you want to be with him or her, and let that keep you pushing, and let that keep you moving ahead. Now, a little bit of practical solution is, if you are finding yourself confused as to what to do, then please make a timetable till the last day of exam, right? Like 10 hours a day, make a timetable till 4th of March. Give yourself daily targets. This is my target for one day. Then divide that into each hour, give yourself hourly targets. And when you have hourly targets, believe me, I used to do that. And I used to work like a rocket, because I know that once that hour is gone, right, I have no time left, and I cannot push and push and push, because at the end of the day I would be left with 1 to 2 hours of something that I have not done, and that makes you guilty if you are not able to, cover whatever you have decided for that. They will create a lot of guilt, and that guilt will push you more forward, right, guys? So all of you are grown up, guys. You are not kids. All of you understand what is at stake, and this is not the time to lay down your weapons. This is the time to get into the ring and fight like a brave warrior. All of you are brave warrior, and remember, nobody is here to give a seat. Everybody is here to snatch a seat away from you. So as soon as you drop your guard, right, someone will shove that sword through your abdomen and take that seat away from you. So never drop your guard. Everyone is a competitor of everyone here, and the best ones, they get the seat. And as of now, we have a lot of time left, and even if you have doubts that I don't know if I'll be able to make it or not, believe me, there is ample amount of time to change yourself in the way that you can still come out victorious, guys. So again, guys, I'll close this Pharmcast with again, Happy New Year to all of you, and I wish all of you have a great day in the exam, and may all the deserving candidates, they come out as winners, and lots of love and blessings from my side. This was Dr. Ranjan, your pharmacology faculty at Mero.